Good afternoon, everyone. I'm Becky Blankenberg, and I'm the president of the APPD, and I am so excited about this combined APPD APA Virtual Cafe. I wanted to give a shout out to Terry Turner, who reached out a few weeks ago and asked if we could do something really addressing health equity and COVID-19. And wanted to really thank our APPD Community Health and Advocacy Learning Community that's headed by Michelle Barnes and by Sarah Garwood, who have worked very closely with the APA Advocacy Committee to put together what I hope will be, and I know will be, an excellent presentation today. They have, as true educators, thought through how to both teach all of us about the impacts of COVID-19 on health equity, and then we will get a lot of time in small groups as well to further discuss in our communities. So a huge thanks to them. It is my pleasure today we have 3 guests who are speaking, and so, oh, and by the way, please turn on your video so we can see you. Please mute so we can avoid any extra noise, and then we will have lots of time in small groups to be able to talk, and please feel free to use the chat function along the way. So, and as you know, we have virtual cafes every day, so please feel free to join us for any of our virtual cafes talking about the effects of COVID on education, and then other things that we all as educators have been talking through. So with that, today we're really looking at health equity and COVID-19 and how has health equity or inequity manifested in the setting of COVID-19, and how can we help our residents and fellows get involved in mitigating the effects of this inequity in the setting of COVID-19. And so first, I would like to introduce you to Rhea Boyd, who is an amazing pediatrician and child and community health advocate who works at the Palo Alto Medical Foundation, and I know has personally taught many of our residents in the Bay Area. So thank you, Rhea Boyd, for joining us.
Hey everyone, I'm so excited to have this conversation today. I'm going to kick us off and do a screen share from my end. The didactic portion of this lecture is going to be a bit of a sandwich where I'm going to start with some of the major takeaways that I hope we all leave our conversation today with. And then Dr. Linton will go next, and she'll kind of dive deeper into some of the terms that we're going to be using and the language that you can use in the small groups around equity and equality, and some of the inequities that we've seen during COVID. And then we'll close with Dr. Bell, who will provide some provocative questions, and then a few more take-homes that you guys can then explore in the small groups. So let me share my screen. Perfect. Okay, so let's jump in. First, I think we all have seen and heard reports about the overwhelming racial and ethnic disparities that have emerged and inequities that have emerged as a result of the COVID pandemic. I highlighted some data here just from the CDC to capture those inequities for particularly African American, Latinx, and Native Hawaiian Pacific Islander populations. Because of these preliminary reports that identified these inequities, a number of public health organizations and even public officials and senators have called for more data, more racial and ethnic data, to help us kind of capture the full extent of the inequities. This data here from the CDC, for example, only captures 50% of cases. So of the federally reported COVID cases, only 50% include racial or ethnic data. And so nationally, we're kind of behind the ball in terms of how much data we could be including for racial and ethnic data. But we also don't want to just isolate the data we're capturing to racial and ethnic data. We want to contextualize it. So this figure is taken from Harvard Center for Population and Development Studies that evaluated the distribution of COVID outcomes by income, race, ethnicity, household crowding, county, and zip code. And what they found is that if you look at the box to the far left that says 2.85 and the box to the far right that says 17.08, what they found is that the rate of COVID deaths is 6 times higher in areas that are predominantly non-white as compared to areas that are predominantly white. And you can see the x-axis is percentage population of color for a county studied. This was a national study looking at counties. If we then look at the Washington Post data that similarly looked at the county level, we see that this is particularly the case for counties that are majority Black, that again, they saw have 6 times the rate of COVID deaths as majority white counties. So the first take home is that intersectional data and analytics really matter when we're trying to make sense of what's happening with COVID-19. And what we mean by intersectional, or what I mean by that, is that we not only want to capture racial and ethnic data, but we want to think about how that data interacts with other variables that we know matter for health outcomes, like place, as was used in the Harvard study, or socioeconomic status, or age, so we can think about children, or education level, or gender. Specifically, using intersectional data will allow us to be really specific about who's affected, where they're affected, and how they're affected. I included one example here. I think we often use kind of catch-all terms to talk about populations that are affected, like people of color. But it's important, particularly during this pandemic, that the more specific the data we have, the more specific we can be about naming the populations that are affected. The other reason we'd want to use intersectional data is so that we can target interventions to the communities who are most affected. Take home number 2. And this one I think is maybe the most critical. 2 and 3 are the most important. So the other thing that we want to do is to avoid equating or conflating the effects of racism on health with the effects of poverty on health. And this is a challenging one, to be honest, because the two are related. We know that racism shapes economic outcomes, but not all economic outcomes encompass all of the effects of racism. And so we don't want to reduce the broad effects of racism to the economic impacts, because we'll miss ways that people are affected. For one example, we know that at every education and income level, African Americans have a lower life expectancy at age 25 than white and Hispanic individuals in the United States. So when we're thinking about how poverty, for example, affects life expectancy, for that example, we also have to take into account how racism might be working beyond poverty, because you see that outcome at every single level. Specifically, when we're thinking about COVID-19, I think we have to ask questions about how racial discrimination, exclusion, and violence impacts the health outcomes we're seeing, independent from populations' economic status. The reason we also want to do that is because if we assume that the disproportionate rates of deaths and morbidities related to COVID-19 for certain communities are a result of poverty, the assumption that we're making is that everyone who's affected in that community is poor. And we know that's not true for COVID in general, and we know that's not true for the racial and ethnic populations who are disproportionately affected. Here's one example of how we should think differently about the relationship between race and poverty. So in the United States, race, not income, is the strongest predictor of access to clean water. And during infectious disease pandemic, where hand washing is really critical to limit the spread of infectious disease, we know that people don't have access to clean water in their household if they are African American and Latinx, perhaps, whose populations are twice as likely to lack access to clean water. For Indigenous populations, it's outrageous. They are 19 times more likely to lack access to clean water in their homes than white households. And so when we think about containing the spread of infectious illness, it's not simply who's poor. We have to think about how residential segregation and public disinvestment in communities together shape where people live and what resources they have to protect themselves, and that leads people to be more susceptible to something like an infectious disease like COVID, independent of the income or educational level of those who live in those households. So one of the take homes I want people to understand is that when we talk about the preconditions that make certain populations vulnerable, and it's important we say make vulnerable and not just that people are vulnerable, the conditions that make people vulnerable are not just summarized by saying, oh, it's poverty, or oh, it's that we have higher rates of underlying illness in these communities. How we should think of it is that the preconditions that make people vulnerable are both legacies and current practices, things we're doing right now that are shaping people's access to resources they need to be well and to keep them from getting sick. And the last take home is that I want to challenge us all to think about how we in our individual practice and at our institution level are addressing both the short and long-term solutions to structural racism. The reason we need to think about that is I think sometimes it's easy to kind of kick the can down the road, especially during a major pandemic, and say, you know, we're going to cover things up right now with a Band-Aid because of the urgency of the existing problem, but miss how Band-Aids actually cover up the underlying problem, and also misses how we actually need to address our dependence on racism in our political economy and our healthcare systems, and that without addressing that, we'll never actually solve the underlying problem. So for one example, during COVID, we could say that one way to address the disproportionate racial inequities that we've seen with death rates, for one example, from COVID, is we could say that we want to universally distribute masks and testing and start that universal distribution by prioritizing populations that are disproportionately affected. You could do that by zip code, you could do that by counties, you could do that by segregated census tracts, and that would go a long way into mitigating current inequities and the distribution of supports available to communities who are disproportionately affected. But if we only do that right now, and we fail to talk about how segregation overall shapes who has access to resources. We already saw it just in my brief slides with access to clean water. We saw it in the data from Harvard with how communities that are predominantly non-white are the ones who have the highest mortality rates. That has everything to do with how segregation shapes who has access to healthcare resources, who has access to other vital resources that keep them from being well. And so we also need to think about ending segregation as a health intervention. So now I'm going to pass it off to Julie, and I actually will not be on this full call, and I'm so sorry for that because I have one other webinar after this one, but I'll pass it to Julie now.
Thank you so much, Dr. Boyd. Yes, as you're doing that, let me just introduce Dr. Julie Linton, who's the Assistant Dean of Admissions at the University of South Carolina School of Medicine in Greenville. And thank you so much, Dr. Linton, for being with us. And you are on mute right now.
There we go. I am so grateful to be here. Thank you so much to everyone. And thank you to Drs. Boyd and Bell for co-presenting today. So I want to take a step back and take that really powerful presentation that Dr. Boyd just shared with us and think a little bit about common language and about making sure that we are all speaking the same language when we're talking about equity. So I've already seen in the chat box pop up the question about what is equity. And when I talk about health equity, my favorite definition is really that we are at a place where we can imagine a world where all people had fair opportunities to attain their health to the extent possible, and their optimal health as they see it for themselves. Many times people use the term equality and equity interchangeably, and you'll see this all in the literature. And the more time you spend thinking about equity, the more time you will notice confusion around language, and we'll talk about some of that. So this picture I really appreciate because it looks at a couple of pieces of equity that I think get missed. So first of all, equality is really when everyone gets the same resource. So you can see here, everyone has the same bicycle. Certainly not the bicycle that they need to be able to be optimally well and to be able to get where they would like to go optimally. On the bottom, equity, everyone has what is fair or just for them to be able to achieve their fullest potential to go and ride the bike. The second thing about equity that this image depicts, which some of the other images that you see around equity don't depict, is the aspirational component. So because they're on a bicycle and because they have the freedom of movement, they can choose to go where they would like to go to achieve their optimal dream to the extent possible. And so I think that's another really critical piece around equity, is that people may define their goals differently, just as we know as providers on an individual level. We need to be incorporating community input as we think about solving problems in an equitable way. Secondly, I think the biggest confusion around terminology when we talk about equity is around disparities versus equity. And these two terms are used interchangeably quite frequently. The quintessential difference here is that disparities are differences and are truly a metric that we can use to measure things towards achieving health equity. Whereas health inequities are differences that are fundamentally due to unfair or unjust problems. And so when you think about that, disparities may in fact be examples of inequities, but when we use the term inequity, we're inherently describing something that is unfair or unjust. And that's a really important point to imagine, because you'll read as you review things in the literature, and as you're teaching your residents, you'll hear those two terms confused a lot. And I think it's really important to spend some time thinking about which one you're going to be using. So this is a depiction of disparities. And as Dr. Boyd pointed out, you really need to unpack this data. When I look at this data, I see the disparities. We can see that at all three levels, non-hospitalized, non-fatal hospitalized, or deaths, Black or African Americans are more likely than Latinx, are more likely than white, and then Asian to experience these adverse outcomes. We don't see in this picture the complexity of race as a social construct and how that intersects with other potentially critically important variables, such as language or poverty or other things. And so as Dr. Boyd pointed out, we really need to be able to take this disparities data and then unpack the equity components of that. So for me, the elephant in the room when we're having this conversation is really around structural racism. And I think this is a pretty scary term. And people get very uncomfortable when you bring up structural racism, particularly in meetings, particularly administrative meetings, which I do a lot, and people are not very happy with me when I do. But I would encourage us, if we're really going to get serious about talking about health equity in this nation, and I think we are seeing this play out very deeply and very imminently in the setting of COVID-19, we need to, in the words of Natalie Burke, who is the CEO of Common Health Action, which is a health equity organization in DC, we all need to get comfortable being uncomfortable. And for all of us, that means really taking a deep look at the structures that support the economic, academic, and health success of some of us and not others. And that includes, for those of us who have the worn identity of someone who is white, unpacking our privilege and the privileges we've been afforded as a result of that worn identity. And it also means unpacking the benefits that we may have received without asking for them or not, how that has impacted our place in society, and how structurally there are policies and procedures that are continuing that. So let's take a moment to look at discrimination and xenophobia. So we are seeing an outlash of racism against Asian Americans right now. And although you could say, yes, that's because of this very specific incidence in coronavirus, it's actually deeply rooted in inequitable immigration policy. The Chinese Exclusion Act from 1882 is a perfect example. We also have a very memorable example of Japanese internment during World War II. But we have to remember that discrimination typically just doesn't happen as a result of a single incident, but it's actually a culture of permitted policies and practices that have allowed those things to become something that one can use against others. Dr. Boyd dove into this, and Dr. Bell will also dive into this, but I think what is important about this piece, and I found it to be really enlightening, is it looks at a very objectively evaluates the unjust policies and practices from redlining to criminalization that underlie the disparities that we're seeing right now as it plays out in terms of the outcome of COVID-19. And when we talk about immigration policy, which is really where I spend a lot of my time thinking, we talk a lot about fear and uncertainty and the impact on families at a time where there is so much confusion, fear, and frank despair among many populations. But we're not talking about fear and uncertainty as an emotion. We're actually talking about fear and uncertainty as a response to unjust policies. So if you remember the public charge rule that has been implemented, there has been no acceptance of the request to suspend the public charge rule during this pandemic. Similarly, the stimulus check and other policies have excluded millions of tax-paying immigrants from relief that would help them to otherwise be able to make ends meet and keep their families safe and healthy during a time of great stress. So when we're talking about resident education, I think painting an entirely bleak picture can be very overwhelming. And many of our trainees, as all of us know, are looking for something practical that they can do. I'm going to offer a few strategies to think about that, and then I'm going to turn it over to Dr. Bell, who can unpack some of this a little bit more. So first and foremost, it behooves all of us to not simply say, please call the social worker every time we experience a social need. And that really means we need to be comfortable with our local resources. In South Carolina, we've created a work group to identify specific resources that are imminently becoming available for Latinx and immigrant communities. And that's a partnership across the state. So there might be something like that in your state. We all have 211 in our communities, and then CAP for Kids is another resource bank that many communities use to be able to resource things specifically for children. But I think making sure that we're imminently familiar with resources around COVID-19 in particular, what food banks and food resources are located in communities where primarily people of color are residing, thinking about place-based resources that can meet the needs, pointing to the inequities that Dr. Boyd referred to earlier. I think it's also really important to remember to use our voices as pediatricians and as trusted voices in our communities, and then to amplify the voices of experts in this field. So Ria shared an incredible stream of tweets around this several weeks ago, and I just included a screenshot of that as an example. So sometimes I don't have the language or the expertise to craft my own Twitter tweet immediately, but oftentimes one of my colleagues who does have that expertise has already done that. So rather than reinventing the wheel, I can simply retweet and amplify that to the audience that follows me. We can also have opportunities to share our voices, and the AAP is collecting a number of experiences right now from pediatricians and trainees across the country to be able to share how COVID is impacting families. It's critically important for all of us as trusted voices in our communities to be advocating for equitable policy. And here's an example of Lori Lightfoot, the mayor of Chicago, sharing very clear language around access for immigrant families. And finally, I think we need to be incredibly intentional around learning about structural approaches in the long term that can undo structural racism. And this very nice perspectives piece offers a series of strategies around undoing those structural problems towards a more equitable future for all of us. And with that, I will turn it over to my colleague, Dr. Bell.
Thank you so much, Dr. Linton. And now it gives me great pleasure to introduce Dr. Shakita Bell, who is the Medical Director of the Center of Diversity and Health Equity at Seattle Children's Hospital, the University of Washington. Thank you so much, Dr. Bell.
Hi, everyone. I'm really thankful to be here. Wow, to follow Dr. Boyd and Dr. Linton is always a true pleasure, but I usually would prefer to go before them. I want to recognize that I'm coming to you from Seattle, which is traditional and current Duwamish lands. And May 5th was MMIWG Day, and so just a little added. I actually started this talk in a different room, but I thought this blanket would be a nice backdrop for the talk today. I also want to recognize the story that's going on in the news right now around Ahmaud Arbery and how timely this talk was in terms of dealing with these very powerful, very charged conversations that we're having as a country. One of the things I heard when we started this pandemic from some folks who work on an institutional side was that we'll get to it. You know, I heard I would raise questions about how are we going to reach such and such community, or how are we going to address this need or this inequity, and I kept hearing, oh, we'll think about that, we just need to get this started. And I just want to remind people that there's always time to address all communities, and especially in a pandemic time, that we must address the inequities that are occurring, and racism must be addressed from the beginning. So as I go through these slides, I'm also going to steal my Twitter feed. This was in the middle of the pandemic, in the middle of March, I posted this. Frankly, I was just really, really upset and really frustrated with what we were experiencing and what we were seeing, and how I was basically being told to just wait. And I couldn't do that. I'm not made that way. So of course I tweeted, but I also took some actions. Our hope is some of the things that I talk about in the next couple of slides will stimulate some thought for you all, and some things that maybe if we have time to break out into groups to think about and talk about with each other. So next slide, Julie, thanks. So first of all, Julie touched on this a little bit with her slide on xenophobia, but I just want to remind people that when this all started back in November of 2019, that we saw and heard a lot of blatant racism from the beginning. There were names that I won't repeat on here, but names that this virus was called that were really, frankly, upsetting and unacceptable. This is a booklet that I'm sure a well-meaning person put together for the kids in our clinic. And one of the things is a little hard. I just took this picture on my smartphone, but the design on the scarf to me was really upsetting. And I also don't like the idea that this virus came to us in a plane from another country. It just really, to me, inferred a lot of xenophobic type thought when thinking about this virus. So both Dr. Boyd and Dr. Linton touched on this a little bit. So these are questions that I want us to think about, and hopefully some of these questions have already popped into your mind. But when we think about the topic of access to healthcare, I'm sure many of you have heard in your own institutions that telehealth is here to save us. It's the great technology that's coming in the future, and we're all going to be able to do such wonderful things with telehealth. And I can say that these are just some of the questions that immediately popped in my head. I work in a primarily Medicaid or uninsured clinic, and many of my families do not have stable Wi-Fi, do not have technology that they can do a telehealth visit in. In fact, I have several families that don't even have an email to get a Zoom link, to much less be able to start a Zoom conversation or meeting. They might have one device for the whole house, and perhaps several children who are trying to use that device for their online schooling right now. There are just so many barriers to think about. And I also want to just make sure that we understand that right now, virtually all telehealth is coming out in English, even just the instructions. You might be able to get an interpreter once you're in the visit, but how do you send an email to somebody who is not fluent in English that tells you how to sign up or set up that call? Next slide. Another topic that I'd like to talk about is thinking about policing. And again, the story around Ahmaud, excuse me, it really rings close to home. The other thing I'm hearing a lot about is this forced mandatory masking, and how maybe some of you have seen the story where folks are laying out on the lawns in Central Park while Black men are being pulled off of buses who are trying to get to work or trying to get home. This is very real and very concerning. I think anytime we have policies that increase the likelihood that somebody can be stopped for very small issues or small, without evidence of breaking the law, I think that we will see dramatic increases of adverse policing. Again, I have personal stories at our clinic of people who are being pulled over on their way to work, and basically because of the color of their skin. The next slide talks a little bit about the financial consequences of COVID, and I really don't even begin to go into that. I think that could be a whole nother talk about what's going to happen on the other side of this after we have 30 million people unemployed and a complete economic breakdown. But I do think in the immediate picture, we have to think about, what does essential mean? What does it mean to quote unquote work from home? What does it mean to miss work, to take forced paid time off, to be furloughed, and who is impacted by that the most adversely? Who has the opportunity to stay home and who does not, frankly? If you are not able to stay home, what does that risk mean to you and your family? The other financial consequences I think of a lot is multi-generational housing and childcare. So who's able to take care of the children in the home? And what we are seeing is a lot of times the elderly member of the family is taking care of the younger members of the family. And when we look at COVID-19, the impacts to the elderly community and how oftentimes children are either asymptomatic or very minimally symptomatic, continuing to spread that through entire households. We have seen in Seattle several times where an entire family has contracted the virus. Next slide. Ableism is another issue that's come up. When I talk about equity, I don't want to just focus on race, ethnicity. I want to make sure we talk about other forms of inequities, including language and ability. So the big solution right away was all these wonderful drive-up testing sites. And I don't know about you all, but immediately I thought about, well, what if you don't have a car? What if you can't quote unquote walk up? How do you keep yourself safe while also trying to seek care? I think that's really important. There was some talk about at-home testing, like testing that people can send out. And I have to remind people that not everyone has a home or an address or feels safe, frankly, giving their address away so that somebody could send something to them. We talked about the public charge rule earlier, and there's a lot of confusion and a lot of fear in communities about being quote unquote documented in receiving care, and this is included. Many of our families don't want to give addresses out. Next slide. So emergency only care has been a really big concern. We've talked about this a lot in pediatrics. What does that mean to only put out the fire and not still be building the foundation of children's health? What does it mean to not be doing vaccines? And then what about not seeing kids who are at home with abusers or whose parents are having interpersonal violence? What does that mean for our families who have to choose between paying the rent and living with their abuser? And how do we address those folks who are not being seen, who are not getting preventative care, who already suffer from structural and institutional inequities in their health, like poor oral health? And how do we address the gap that is even widening while we don't have dental care or adequate oral health? Incarceration is a really hot topic right now. Probably many of you have heard the conversations about how do you social distance in a 12-by-7 cell with 2 inmates, and how do you keep people safe, that COVID-19 is just running through jails. I would like to back up and even say, why are we incarcerating children, and what good does that even do? This is just one more reason why we shouldn't have kids locked up. But I will point out, since I can't make jails disappear right now, as one of my long-term goals, is that we do know that Black youth are disproportionately incarcerated. And so that also drives this disproportionate rate of infection and exposure and lack of access to care, since most jails and facilities that have children confined do not have adequate access to care. We can also think about that in the detention centers as well. Next slide. This is a very controversial topic and people don't like to talk about it, but the crisis standards of care or mass casualty plan, most trauma hospitals have 3 stages and crisis is the last and final stage. And some hospitals did get to this state and some in New York are still here. This is the idea that we have a limited set of resources that we have to then determine which patients or families qualify for that intervention. And what we have heard over and over again is how great it is that we are blinding race and ethnicity in those decisions. I actually think it's problematic that we're blinding race and ethnicity and language, because we are not addressing the very real health drivers that social, structural, and institutional racism have caused. It also doesn't blind to ability. So the sense of worth of somebody who has a disability is weighted directly against somebody who does not. Also, age is also weighted. Again, I think we need to have a conversation as a society and as a country about what these social constructs have created in terms of inequities leading into this decision. So in closing, I just want to mention this way of thinking or of framing things. Rhea touched on this a little bit, just the idea that being Black or not speaking English is not what makes you more at risk for catching COVID-19. And she touched on this also with the poverty. That is not the key problem here. It's that these infrastructures have built an environment that puts people at risk. Society has put Black and brown people at risk for COVID-19. The other thing I'll just point out before we go into questions is that these topics are all really broad and all of these questions are running through our heads. I found myself really overwhelmed, and what was helpful is to start attacking one at a time. So I think as we move into the question portion, which I think we do have a little bit of time for, I think it's really important to focus on what you can do. What do you know in terms of inequities, disparities, equity, diversity, inclusion, recruitment, training? What do you already know? What have you already been taught? What tools do you have? And how do you harness the energy of your learners to move this work forward? And that's not easy. None of that is easy. None of the things we've talked about is easy. None of this will be done tomorrow. All of this is going to be long, very invested work that takes all of us, that takes the whole community to make a difference. But I think we have, I mean, with the 200 people on this call, a good momentum to be able to start addressing some of these things. With that, I'll close and we can talk about going into small groups. So,
yeah, go ahead.
Oh yeah, so I was just gonna, I was gonna set some ground rules. I think it's important anytime you break into groups you know, our small groups are not going to be very small. So it's important that we allow people to talk. Whenever we talk about these sorts of topics, it's really important to also be listening. Thanks, Julie, for putting these slides together. I think the respectful talking part is really important and something I have to remind myself because I'm such an external processor. The why am I talking and why am I not talking question is really important. Make sure that you ground yourself in I statements. So this is the way I feel, or I was taught, or I'm noticing this, so that you are owning your own portion of this conversation. I also always like to say this is confidential. So the examples that I've already used, for instance, that happened this week and last week, please don't share outside of these conversations. They're more to build a connection between real life people and real life patients and these concepts. And if you do want to share something like that, please de-identify the people who are involved. I'll let you read the rest. I hate when people read slides to me line by line. Yeah, and then I'll let Becky, I'm not sure, or Sarah, who's going to break us into small groups.
Yeah, so actually, Rosemary, what we're going to do is we're going to break into 4 small groups, and there will be 2 facilitators in each small group. And these are just some questions that we're going to discuss together. So we think that Zoom will auto put you in a small group, and Rosemary's going to help us with that. We're going to be there for about 10 minutes, and then we will come back together to share some resources, and Dr. Bell will help finish us up. Excellent. Welcome back, everyone. I know that was a very brief time for us to have a conversation, but I hope that it helped. Dr. Bell, I don't see you on my screen, but are you able to finish off for us?
Yeah, I'm here. I'm going to put my email in the chat box. We had a really great conversation in our room about how inspiring our residents are and how they're on the front line of this work, and that they understand the really unique power dynamics that we're experiencing in medicine right now. I do sit on a national call on Fridays at 12:30 with several people across the country who are specifically trying to address inequities in telehealth. So if anybody's interested in joining that call, it is open. We are trying to keep it Zoom protected. So please email me and I can send you the invite instead of just posting it. But I think coming out of the groups, it was really great to hear the conversation in ours, and I really appreciate everybody for speaking up and being a part of the conversation. I'm going to ask in the other groups if I could have one person just share really briefly, because we have like 5 minutes, about kind of just one summarizing statement about what conversation you all had. And Julie, I'm going to call on you first because I know you weren't in my group.
Absolutely. I think a few things that came out of our session were strategies around making advocacy equity references real time around case examples as we were precepting, around using social media, which is something that our digital native trainees are often much more comfortable with, and around integrating with our chapters in terms of collating advocacy efforts.
Great. Can somebody from the third group, I can't remember who our co-facilitators were.
Melissa and Kara.
Oh, wonderful.
Hi. So yeah, we spoke a little bit about what programs are actually already doing. And I think Melissa summarized it nicely. Some of the work they're doing is around sharing information about resources that are available, sharing data about what these inequities are and why they exist. And then also some amazing work being done about having residents provide direct resources to communities in need. For example, people in homeless shelters. And then we had a nice discussion about some of the advocacy that's being done on a legislative level among different programs.
Great. And then the fourth group, can one of the facilitators summarize? Michelle, you might have to help me.
Yeah, I think that's Padma and Leora.
Hello. So in our group, we talked a lot about existing curriculum that's been there as far as talking about health inequities and how maybe to take some of that material and transition it and utilize that same material for this COVID, as this COVID has been emphasizing these inequities. The other thing we talked about was especially in programs that have residents that are on the front lines, other programs have residents that are staying, that are more homebound, what can be some curricular development for those programs. And so we talked about some podcasts and different programs shared some of the work that they're doing in regards to that.
Great. Thanks so much, everybody. I will say the summary of our group is that the charge is to us as faculty to catch up to the residents, because they're also woke and have this vernaculum, these words down so well. I really appreciate the depth of conversation that each group had. There's a bunch of resources on the slide deck, as you can see. Another reminder, somebody put this in the chat box, it's such a great piece. This would make an excellent research focus for a general academic PEDS fellowship, so that's a really good plug there. And then I'm gonna hand it back over to the APPD crew to talk about the other notes for today's presentation.
Becky, I think you had a couple more slides, but before I hand it over to you, I just wanted to, for Sarah and I just wanted to really thank Dr. Linton and Dr. Bell and Dr. Boyd for putting this together very quickly. We all spent a lot of time talking about this. I know they spent a really long time working on this with very short notice. So I really, really appreciate their time in doing so, as well as everybody from the APA who's been really helpful too. Kara, Leora, Padma, Melissa, and I'm sure I forgot somebody, I apologize. Anyway, so I will send it back over to Becky.
Thank you so much, Michelle. I really want to thank all of our speakers today. This was such a powerful presentation, and really you gave us the language, knowledge, and a starting place for how we can really start addressing these inequities due to COVID-19 and more broadly. So thank you for taking the time to lead us today. We had one last exciting piece of APPD business that I wanted to share, which is our awards. Please be watching your emails for videos announcing our 3 national award winners. And for those of you on the call, you're going to get a sneak peek. The Carol Berkowitz Award is presented for advocacy and leadership in pediatric medical education. And huge congratulations to Catherine Maynard from Johns Hopkins University, who won the award this year. So you'll be seeing her video accepting the award in the coming weeks. And the Robert S. Holm Award is presented to Michelle Nichols, who is the program director at the University of Alabama at Birmingham. And she received this for leadership and mentoring of pediatric program leaders. And last but not least, the Walter W. Tennyson Jr. Award is presented to Bob Vinci, who is the chair at Boston Medical Center for Advancing Pediatric Research Education. So a huge congratulations to these 3 award winners, and really a huge thank you to our speakers again today for bringing these important topics forward. And thank you to our partnership with the Academic Pediatric Association and to all of you for being on the call. Thank you.
Thanks, Becky.
Fantastic.